I think you'll have to give me the access, please. Oh, you got it, yeah. So, Shanuf, can you see me?
Yes, sir. The audio and the visuals are fine, sir.
All right. Thank you, Shanuf, for your kind introduction. And good evening, everybody. It's nice to be back after a long time, especially on this online platform. During COVID, I think every other day we were speaking on online platform, but now the on-site has become popular again. But I agree it has to be a hybrid version. There are few who cannot travel up to me, and I couldn't travel up to y'all to meet up on any occasion. So this is one such platform where we can have short updates. And I'd like to congratulate the Safe Dental Updates, the entire organization led by Shanuf and his friends. And welcome again for this concept. I've been given a topic on irrigation dynamics. It's an interesting topic. So in the next 45 minutes or 50 minutes, whatever best possible, let's try and cover up. First of all, when you have to think of root canal, we have to divide into three major stages, three major steps. Firstly, it's mechanically preparing the root canal. When you prepare the root canal mechanically, we used to call it biomechanical preparation. That word is actually gone now. We talk as cleaning and shaping. In fact, cleaning comes even before shaping. Of course, you have to shape to clean. I'll come to that. Next is chemical preparation. And then comes filling the system, drying and root canal filling. So these three becomes a major part, of which the most important part is the middle one, where we have to disinfect the root canal system. Unfortunately, around the world, this is one step many of us are shorty. We're short of job when it comes to cleaning the system. Let's see what has happened and why and all those things. This was my story when I was doing my consulting practice. Maybe 15 years back when I was doing my consulting, we used to jump from one clinic to another. You had a stipulated time. We did a lot of one-visit root canals. And if you ask me, we used to go into our master cones, put the master cones, things are good, seal the root canal and send the patient. It's a mechanical objective. Of course, your root canal files have gone there, maybe hand, maybe rotary, maybe combination, whatever. And then your GP points go there, you seal the system. Have you removed the smear layer? Have you cleaned the biofilm? Have you removed the bacteria 100% or close to 100%? You can't do 100%. That's why we call it a disinfection and not a root canal sterilization. Now, I want to show you two pictures. This is what woke my eyes when I started using microscope in 2003, 2004. Extracted tooth at 8 times magnification. On the left side is prepared root canals, but uncleaned. The right side is prepared root canal, the same root canal, but clean. Now I'll show you at 24 times the normal eyes. It's magnification, right? It's microscopic view. On the left of me, you see the white dot, debris, and everything possible. The GP point, what I had put in the root canal system, would also go into this canal. Everything looks nice. When you obturate, maybe you'll get a puff, you'll get root canal, sealer, condensation, looks all good. But sometimes I started realizing the root canal still started failing. Garaparcha to a root canal space is like how suture is to a wound. When you suture a wound in a site, any site, sutures don't heal wounds. What heals a wound is what? Irrigation, medication, and the rest. That is what we need to do. So please, if anybody, so what used to happen, the minute I do my master shapes, those days I used to use a lot of pro tapers. When I did my F2 or F3, I would always tell my staff, come on, mix the sealer, bring the things and put the GP point, paper point, dry it, obturate. Today, my whole concept has changed. After my master shapes are done, that's when my irrigation starts. So I actually will give a good 20 to 30 minutes of irrigation post shaping. If there's one thing, if you can change in your practice, believe me, there's no other word except being successful. Why do I say this? We all have seen our share of failures. We've all grown that way. I've had mine too. But today I'm very clear about what I'm doing. I know my success rate has changed drastically, only because of this irrigation protocol. And I'd like to thank Shanu for actually giving me this topic. I was asking him, I've got a lot of topics. Some of my more favorite topics are there. He said, no, sir, the crowd, the participants want to listen on this. I said, fair enough, we'll do that. Right? So I'm going to be fundamentals. Now you see that white debris and dots, they may be a smear, they may be a biofilm, they may be bacteria, they may be debris, whatever. Why do they happen? This is one system of root canal preparation. When you use the system or any system, it cuts dentine, right? Because it's a rotary. When it cuts dentine, the dentine that's cut is not always taken out. It is so difficult to remove things from the root canal system. When you cut dentine, it gets slapped back into the same system sometimes. No matter how good you irrigate, it's still not enough. That's why we will see what protocol we can follow to make it even better in the slides to come. This is one of those pictures I picked up from the system or the social media or the computer or the internet. This is exactly what they're trying to show. ESCM means, I know there are general practitioners, private practitioners, is environmental scanning electron microscope. All what this slide is showing you is fresh, cut, open dentinal tubules. Maybe it's bacteria, minimized bacteria free, and that's what we want. I want my GP, my sealer, to go and entwine into the tubules. It gives you mechanical locking. It seals into the tubules, intra and inter. To get that, your system should be clean. You need to get there to do all that. How to do that? First of all, what I'm going to show you is a simple picture. This is not new. Many of you may have seen it. On the left of me, you see entire green root canal system, which is not prepared. On the right, you see, these are micro-CT analysis, okay? A computer topographies. On the right, you see, there's red and green. What is red? Red is nothing but a prepared root canal system, but you still see green. At this point of time, I want you all to remember a lot of irrigation specialists, some of whose names are here. Ove Peters has come many times here. You have to think of Frank Parquet, you have to think of Matthias Zender, you think of Hapasalo, Otuskis, or you think of Indian people like Anil Keshan, or Prasanna Nilkantan, or Gopi Krishna, or Vasudev Ballal. They're all Indians. They all have worked a lot on research with respect to irrigation dynamics. The reason I'm giving you is if there's any postgraduate, when you get a question on irrigation, there are good papers you have to pick up from. You'll get some key articles, landmark articles, some good review papers, and what? All what these people said, many of the good researchers said is, whichever system you use, the red is a prepared root canal, I said, whichever system you use, let it be hand, let it be rotary, let it be combination, step back, step down, crown down, hybrid, whatever. 30 to 35% of the root canal system still remain uninstrumented even after you've done the master shapes. When I say master shape, is the working width. One is the working length up to where you go, right? Next is the working width. How much do you enlarge? The last 3 millimeters or last 4 millimeters, because that's our zone of infection. The rest of the root canals are means to an end. You're opening the top, getting the coronal 1/3, going down to the middle, going to the apex. When you reach the apical third, that last 3 to 4 millimeters is how you clean. That's the critical part. Because with the zone of infection, if you've not done well, then you have zone of contamination, irritation, and stimulation. If it has to get stimulated, if you have to have reversal of the periodontium, where there's bone fill happening and normalcy coming back, you need to clean the system because hideout is a root canal. If that last 4 millimeters are cleaned well and shaped well, endodontics is yours. So when these speakers, when these researchers have said 30 to 35% or even more is not shaped well, which means there are undercuts in the root canal. Root canal files take the outer curvature, be it hand or rotary. They take the bulge, they take the convexity, not the concavity. They don't take the undercuts. And there's plenty in the root canal system. There's cul-de-sacs, there's fins, finger-like extensions, irregular anatomies, plenty in number. I'm not only talking about the main canal, the lateral, the additional, the accessories. I'm not talking on those. I'm talking of the one system, one root canal, which can have all the other things. So that's where you need to spend time irrigating the system. That's why this topic has come up, maybe, First things first. When you go for irrigation, what is it that you deliver with? You need a needle, right? What type of a needle do you want? We have the bevel needle, we have the side cut needle, side vent, blunt end needle. This is what books have taught us. But are we following it? Even today, I see some of my students or otherwise still following this type of a needle. It's an injection needle. It's got bevel. Bevel is given for it to puncture into the tissue, the soft tissue, to go and land where it's supposed to. That's why you give a bevel. If somebody said, I use this for irrigation with saline, I may accept that. You want distilled water, fair enough, go ahead. It does less harm. But if you say that you're going to use this needle to irrigate a root canal system, where the needle has to actually go into the zone of infection, which is the last 4 millimeters, then I think we are in trouble. Because this becomes like a piston and a cylinder. It becomes like a one-way traffic. See what happens. Ideally, you're supposed to eject the solution, not inject. See the outflow. See how much is going out. I know there is interstitial fluid, there's bone space there. It may not let so much to come in. But if any irrigant goes this way, other than saline or distilled water, or the famous hypochlorite, which we talk of higher percentages, 100% there's going to be a flare-up, which you and I, nobody wants it, right? So let's see how to be careful. My take today would be, first things first. I'm going to be very basic in my presentation. I was just asking Shanuf in the morning, what's my target audience? Because we also speak to the postgraduate level with a lot of references and research and studies. But I'm going to be very clinical here, and I'm going to be very, very practical here. For me, the bevel needles are out. Only if it is saline, okay. If it is distilled water, I'm good. Otherwise, it has to be a side vented or a side end needle, a blunt ended. A side cut is also okay. Side cut is not popular in India, so side vent has become very popular. So if you see, the bubble of solution that's coming out is from the side. It's a blunt ended. Or if I have to show you the small video, when I'm trying to deposit, it's having an outflow from the side. This will help you, even by mistake or by purpose, if you deposit it faster than needed, faster than needed, you will not have ejection or extrapolation of the solution out to the root canal system into the bony spaces. This is one of the main reasons of post-op flare-up. There are many other reasons. Now we saw which needle. I told side vented needle. That I'm talking because we are talking now of a solution called hypochlorite. Why hypo? I'll come later. Now that particular needle, because that's a means to the end, right? I'm coming backwards. We have two types of needles. We can have even 23, 24, 26. They're all injection needles. I don't like them. Because root canal systems, after you prepare to 25 size is 0.25, even these needles won't go in. You have to prepare to a size minimum of 25, if not 30. And then a taper of 4 or 6. Then possibly you'll end up saying my 27 gauge is going at least to 3 or 4 millimeters from the root end. Why? Because 25 millimeters at the root end, 4% taper, every millimeter you jump up. 24 plus 4 after 1 millimeter, plus 4 after 2 millimeters, plus 4 after 3 millimeters, plus 4 after 4 millimeters. So 24 plus 4 is, 25 plus 4 is 30, 29 plus 4 is 33, plus 4 is 37, plus 4 is 41. So about 35 to 40 will be at 4 millimeters, where possibly your 27 gauge is going there. That's why I said my irrigation starts after my shaping is done. So you have two different needles, and I'm going to show you some examples here. This is, of course, endo blocks that have been prepared. When you bend the needle, you're bending it at the reference point, not just for the name's sake. So now we have a 30 gauge needle there, and you have a 27 gauge needle. See both these needles up to where they're going. Are they going to the zone of infection? I'm finding it difficult to take there. Ideally, this needle should go 2 millimeters short of apex, 3 millimeters short of apex, or the apical constriction should be 1 or 2 millimeters away from the tip of the needle, not far. When you start irrigating from the beginning, you've not prepared the root canal, nothing is going in. There's a lot of backflow and outflow. You think, oh, lovely irrigation, things are coming out. I'm not bothered of things coming out from the top. I need the irrigation to happen at the apical third. That's where my root canal system begins. And that's where the entire problem of the root canal lies. So here's an example. Now, I'm going to give you another example. Here's an open apex. I have a double-vented, blunt-ended needle. If I irrigate with this, and maybe if it's a 5 cc syringe, or if it's like a open apex with a 5% hypochlorite, we had it. Please be very careful. In open apex, you're going to use diluted versions of hypochlorite. The argument will be what, when it's a 5%, 6%, people also talk of 8%, activated, we'll come to all that. What does it do? It gives you a disinfection for sure. More importantly, what it gives is tissue dissolution. It dissolves the pulp tissue. What 3% and 1.25% or 2.5% does not do is the tissue dissolution. If you increase the volume, if you double the volume from, instead of 5%, 5.25, you can double the volume and use 3%. If you make it 4 times, you can use 1.25. Nobody's going to debate on that. You're still going to get the disinfection. Yes, tissue dissolution may not happen. That's why we say always use a concentrated 5.25, which also will help you do a faster and shorter irrigation time and protocols. Please don't take the needle to the root end, please. Open apex, never concentrated. I pull the needle far. Now it's too short. So you need to have a needle not too far, not so far, and not so far either. It should be somewhere in between. And in an open apex like this, with a large periapical lesion where 2 teeth got extracted with a young individual, not done. I want to save this tooth. Somebody told extract this tooth also. I said, no, we'll regenerate the bone. Maybe we'll get an implant. I may have to do a surgery, maybe. We'll do all that. But no extracting one more tooth. It's a young IT individual. Ignorance was the only reason, nothing else. Okay. So we spoke about needles in brief. Let's go to talk about the next part of the needle. So after the needle comes what? What's the attachment to the needle? The attachment is what? A syringe, where the solution lies. It has to be leer locked. You see the threads at the end of it where the needle is going to be attached? That's more important. We use snap-on. In the snap-on, when you try and deposit, needle can fly. Forget that. Needle can leak. I don't know how many of you are using rubber dam, which is actually mandatory, but be careful on this. When you're using a leer lock, both of these won't happen. And more importantly, I needed to buy needle syringes, which are only 2 ml, not the 5 ml or 10 ml. They're all for veterinary, not for dentistry. Why? Because I know 5 ml will take a lot of solution, but you don't get that threshold to press it. You need to create a thrust for the irrigation to go and work on the walls. There has to be a good flow, not just linear, but it should be lateral turbulence called laminar flow. And there are different flows in this. I'm not going to confuse you with all those things, but just understand this much. Your needle is at the last 2 to 3 millimeters with a 2 cc syringe. The flow rate is also important. So 2 cc or 2 ml syringe really makes a trick for you all. Now, next point. Can you have colored needles? Of course. A lot of companies are giving you this. Hager is one of the companies in India which will give you this. Buy colored needles. These colored needles, you can choose. You can hypo, generally it's dangerous, so we put red color. Maybe the other colors you can change the way you want, but standardize it every time. You can't say once blue will become ADTA, once it will become citric or chloric serine. No. You can decide. And the one which is not colored can be just saline. Everything is good. But standardize your protocol. It's a very important step and it's so easy to do. When you pick up hypochlorite that is freshly prepared or with a near expiry or a short expiry. When I say that, it's like freshly prepared. I don't like 2 years long expiry dates. Or I'd like small bottles and not big bottles, because hypochlorite is a chemical which will dissolve or disintegrate. which means hypochlorite becomes hypochlorous acid, which we want. But if you wait longer, it becomes chlorine, which also we want. But if you wait even longer, it becomes water, which is a diluted version, is no good. That's why please don't buy big jars. It's of no use. Buy the smallest bottle. It's one of the cheapest chemicals in the market. Buy amber colored because light will not interfere. And more than that, try and buy something that's got lure lock. What I mean by this is your syringe is coming. You can lock the needle and try and extract it straight into that. From the bottle, straight it goes with the needle into the canal system. Some of them, I used to do this before. We also have this system where you can load the hypochlorite or any other irrigation into this jar from where you can preload the syringes. Why am I speaking so much about all this? I have seen accidents. In my consulting practice, some dentists used to start and I used to go after that. And I ended up seeing a lot of accidents. I can't put the real pictures, so I've just picked up some textbook or some internet pictures. This top picture that you see is drooping down here. The dentist was not wrong. The dentist was focusing straight on that molar, the mesial canal. The needle was there, but the attachment where the needle and the syringe was tied up, the thread was not there and it was leaking continuously. There was a block given and the hypochlorite leaked so much till the bib got dirty. But the patient was sensitive, the skin was sensitive. A lady patient, imagine. Anybody will excuse you for anything that you can hide maybe. A face value? Definitely not. It was a big issue in that clinic. I know what happened. They went to a skin specialist. They gave them all steroid creams and whatnot. That patch, that burn, chemical peel took a long time to settle. You'll not be excused. And that's not possibly your mistake. The only mistake was there was no lure lock. That's it. Sometimes I've seen these accidents where hypochlorite is leaked into the palate. Again, no rubber dam. That's a different thing. See the chemical burn. This is not acceptable. The patient could not eat for a week because of so many particular like hemorrhages and minute aphthous, ulcers, stomatitis. Or I've seen another picture here of a patient, which I saw somewhere. See how it is. This is, of course, hypochlorite has gone through and through into the system. Not accepted all those things. So if you have the money, if you have the money to invest a little more, other than the syringe and the needle, I would ask you to get micro aspirations. Micro aspirations are very simple systems. Ultradent will give you, Circumed will give you. There are many systems they'll give you, okay? All you need is the front piece, what I'm showing you here. I can go into a simple chair system. This is my college system. In the college, we have confident chairs where we put in the high vac. And what we do, I tell my assistant, please hold it in the floor or into the canal, and I will hold it for you and show you where to, and don't move after that. And now you see. Now I'm going to irrigate. When I irrigate, the 2 cc, 5 cc, 10 cc hypochlorite doesn't matter. There's rubber dam anyways way, but nothing is going to come out. See how the irrigation happens. I'm talking when I'm working. And then you dry the canal. You wait there longer. By doing this, you need less paper points. If you can have a microsuction, another C-shaped canal, see this. It's one of my old videos. I started from here. This is about 15 years old video. One of the old microscopes. So if you see the quality of the image is old. But I wanted to tell you that I have started then. All my assistant does is locks a microsuction needle and holds there and see how the suction happens. And I'm depositing solution on a constant flow every few minutes and seconds. And you get a clean system. There's no rocket science. It's a very fundamental, simple system. If you don't have that, use any system, any needle, any syringe, a lure lock one again with the stopper. Stopper becomes a big reference point in endodontics for all of us because we don't know how far the other end is. I know we have apex locators, working length with radiographs and combinations and whatnot. But this is a wrong picture. This is actually my own picture. I purposely made it. You know what I'd say? If there's a stopper, why not adjust the stopper to this level? Now you see this. My stopper is touching the tooth and that's where it stops. I should not go beyond that. I should not be shorter than that. That's when I know my 27 gauge needle, my 30 gauge needle, 30 is more thinner, right? 30 gauge needle, my hypochlorite irrigation actually is going to the root apical third. Then I start irrigating. I have a microsuction next to me. And then when you start, you'll get turbulence. This is the initial part of the irrigation. There may be bacteria, there may be tissue, there may be chemicals that are interacting, and you'll have a lot of turbulent fluid. And see what happens in the next slide. After a few minutes, you'll start realizing the color starts reducing even lesser. And then it becomes more clearer and then more clearer. And now see the solution. The canals are almost clean. Activated, I'm coming to activation now. Activation of a chemical is a most important concept now. Heating and activation, we'll see a little later. Now I know my canal system is clean. And then I aspirate it. You can micro aspirate it. How do you do it? You can take a larger, longer, broader needle, lock the needle into the system, and suck it dry if you don't have microsuctions. Microsuction is one good system to do it. Like beginners, youngsters who don't have the access or don't want to do it now, fair enough. Do manually. Otherwise, in endodontics, there's nothing you lock. You lock only two things. One is for intrapulpal or intracanal anesthesia. And second thing is for microaspiration, manual. When you deposit irrigation, you don't inject, you eject. And needle is always passive, please, no active. If you do active and deposit, it's going out. We don't want that, right? So that's where it is. And now see the root canal. It's pretty clean. But to get the root canal so clean, it's taken me time. How much time? 20 to 30 minutes post shaping. Coronal 1/3 looks all round and circular and nice. That's all I can see. Can I see the middle third? Maybe under the microscope. Can I see the apical third? No, because it's curved canals. I have to rely on my tactile, my other experience as we go through. Here's another picture. You see the small bubbles on the lateral? When that stops coming, you know the bacteria is taken care of. There's no oxygen liberation. The chemicals are not reacting anymore. You need to have a clear fluid. When bubbles are coming, they're still oxygen liberating. Till then, you should keep activating. That's the rule of activation. And that's a biological concept. Mechanical, everybody can put a root canal file, put 2 GP point things, will go there. But like I said in the beginning, have you cleaned the system? I doubt. So that's one big thing I've changed in my practice for a long time. So I come here now with the needle, with the syringe, with my activators to do a mechanical activation. The same picture that I spoke before and after. And now we're talking what? Why do you need to do it? My instruments have shaped the system. Has it cleaned? No. Will my irrigation clean? No. If I go to the apical third also, the irrigation may have a lateral turbulence, a whirlpool, a whirlwind effect, whatever you want to call it. Still, it's not enough. You need to have something called mechanically activating a chemical, a medicament, a sealer, a solvent, maybe even an etchant. Why? Because this word is not used anymore as much, called vapor lock effect, but it can produce bubbles inside, air bubbles inside, air pockets inside, negative pressure inside. The surface tension of the chemical may be different. The contact angle of the chemical is different, because of which the irrigant may not have reached where it's supposed to reach. And that's why I want to use an activator to break down that bubbles, to carry the irrigant deeper up to where it's supposed to go, and then touch all the walls. That's the concept. So I'm going to show you why we're doing that. Now, this is, of course, a slide from University of Vienna. I want to thank them for this. They've done some studies. You see all the names. I'm not going to talk about that. They said you prepared a root canal system and then you're irrigating, even with the hypochlorite, your chemical disinfection, which means the dentine gets soaked. The soaking of the dentine, the penetration of the irrigant is not only 100 microns. But bacteria, even after you prepare the root canal to 20 size or 30 size, you're only preparing how much? At the end, you're preparing 0.3. At the top, you're preparing maybe 1 millimeter or 1.2 millimeters, not more than that. How much is the root thickness? Maybe 2 millimeters, maybe 3 millimeters, maybe least is 1 millimeter. Bacteria can hide into the dentinal tubules up to 1.1 millimeters, which is 1,100 microns. 1,100 microns is the depth of bacterial penetration. And that's what they try to prove when you use a laser, because of its deep thermal effects. And the newer lasers have got even other activities. I'll come to that a little later, of trying to replenish the system of activating and irrigating solution. So that can go more than 1,000 microns to disrupt. And that's what you want. Okay. There's an entire spectrum of bacteria here. I'm not going to talk about all these things. All what we need to know, some of the deadliest bacteria. Like one I'll talk about thing here on the screen is called E. faecalis, called Enterococcus faecalis. It's only about 5%, but it's very nasty, very stubborn. In painful pulpitis, blame it. Failures, you blame it. It persists for a longer time because you see the slide, they can live as a mono infection on its own. They need very little nutrition. They persist even after treatment. And that's few more studies here. So all these people have told this, and if you saw the Journal of Endodontics, maybe 2012 to about 2017, that 5 years had plenty of articles on E. faecalis, only E. faecalis. Today we know it is E. faecalis, and a lot of chemicals don't work on E. faecalis. Not even hypo as much, not even your calcium hydroxide and nothing else. So that's when possibly laser became popular. I'll share my views on both of them. And then you have plenty of activating things. So you need to activate, irrigate, combination with hand, with rotary, with sonic, with ultrasonic, with lasers, or any one of these. So here are a few examples. I will only say in a joking way to my students, my participants, I ask them, how much money do you have? If you don't have a lot of money, don't go with all the gadgets. Manual dynamic activation is what I'm showing you. You can actually even do this. Nothing wrong. But be careful, you're not hitting the apex or apical third end of the apex as much, because I don't want post-op trauma. So you can use a hand file. You can use an irrigating needle, but the plunger is out, and then you hold like a pen, and then you go on activating the needle itself to just make a small little movement of the irrigant. But the commonest one in manual dynamic is always been a GP point. You would take a point one size larger than the master cone or two sizes larger, just because you want to be a millimeter or 1.52 millimeters away from the root apical constriction. Because that bubble that you want to break down by doing the manual dynamic is what you want the disruption to happen. But manual dynamic with GP point is kinder compared to the other two I showed. But manual dynamic, the only problem is what, you have to do 50 to 60 times per minute. So literally you're shaking the patient's head along with you, which I don't accept, right? So that's the problem with manual dynamic. Can you use something else? Of course you can. This is nothing but, can you use something else? Of course. This is a video where using sonic activation. There are so many sonic activators. Endo activator became very popular. It is still used. It's a to and fro motion from 2,000 to 5,000 to 10,000 cycles per minute, and you're going up and down. So the to and fro motion, you're going up and down. It forms bubbles. It gives some decent amount of activation. Will it be very, very effective with hypochlorite and root canal disinfection? Debatable. But it's second best to none. You can definitely use it. It's a very practical solution. To coat calcium hydroxide, sealer, all the rest, definitely you can use it. Can you use a rotary like this? People have tried even this. Nothing wrong. Everything is good. It's a plastic file with a stopper that you go up and down in the same rotary motion at a certain RPM, and you clean the system. Can you use an endo finisher? One of the closest proven rotary for good chemical disinfection. Why? Because see the end of the file. It's an XP finisher. It's from FKG. It's got an umbrella. It's a hook. So when the rotary turns, it's going to touch the wall at different levels. And when there's an irrigant there, it's going to cause disruption of that system. You have to do with hypochlorite. You also have to do with, say, EDTA, liquid EDTA. I'm coming to that a little later. So you put in the system and start activating. Go apical middle coronal a couple of times. Minimum is 1 to 2 minutes per canal. So that's what you do. This is about endo finishes. Go in and out very passively. Don't get it bind into the canal. That means your canal is not prepared enough. It can break, and it is broken. I've removed them also. I've seen them, right? What about these? These are ultrasonics. It's called Irrisafe from Satellite or now Acteon. Very effective. You get this bland files, non-cutting files, where you put irrigation and mechanical activator. They're definitely better than sonic. But then you need a good power generator. When I say power generator, it's the scaler. Do you have some more systems? Of course, I'm only showing you the systems I've used. Maybe there are more in the market, more in the world. I like to invest in a lot of endodontics, and we have this. So here you see, this is called PATS. Again, it's a sonic. It's an air sonic, I would say. We use a compressed air. It's like a handpiece. It's got a plastic polymer tip. With the stopper, you're going in and out of the root canal system with the irrigation in place, and you're activating thoroughly. Have I used this? Of course. Today we have another system, a modified system of this. They're sold by Coxo. It's called, this is continuous wave activating irrigating systems. So if you see this video, you'll find this here. There are two needles, one longer than the other. So one is depositing the solution, other is sucking it simultaneously. So the flow rate is decided, the sucking rate is decided. There is a one positive needle, one negative needle. And there's also the other way around. So one is for the coronal 1/3, one is for the middle 1/3, one is the apical 1/3. Now what I'm showing is the apical 1/3, where I'm depositing the solution at the top, and from the apex it's getting pulled. So that's what you want to have, okay? There are different cases of this. Now this is nothing but root canal irrigation systems and suction irrigation systems. So that's what we're doing. And then here, this has got importance because somebody said earlier that heated hypochlorite is better. So we used to heat with baby bottle warmers, beakers, preloaded syringes, and take it in systems. When you take that, what happens? There's a loss of energy. The heat is gone. It's proven fact that heated hypochlorite works the best in the root canal system. So now what we decided is we have this root canal Gadaparcha cutting systems called down packing instruments. We heat it to 180 degrees. For about a minute, we go and deposit in the system and then heat it. And it goes to the system and see the hypochlorite bubbling. It gets heated. See the axis cavity opening now. This is called caries-driven axis. I've never started the axis on the palatal side. We've started the axis from the lateral side or the proximal side. So in that system, if you see, we just heat the hypochlorite in the system itself. Can you use this? Of course. This is lasers. It's called photon-induced photoacoustic streaming. So here we use this. So if you see this video now, we are activating the laser. See the amount of debris that's coming out. I'm using the laser at the entry point. I purposely kept the debris on the mesial roots in the entry point. The tip is kept at the entry point and not in the chamber and not in the canal. This is an all tissue laser, and see how clean the canals have come. In fact, I want to tell a little more on this. I know it's not affordable for most of us, but someday when it is, this is one of the only systems that can work today. Right? There's another system in the US called Gentle Wave. It's not reached India. There's a lot of hue and cry about the system. A lot of people are speaking high about it, but the cost is, I think, screamingly expensive. So this is one of the laser dentistry journals or articles that we published. We published here an SCM analysis on an extracted tooth, of course. We did smear layer removal of different irrigations. I'm only going to show you on lasers. We did sectioning at coronal, middle, and apical. You can get clean system at the coronal, fresh open dentinal tubules this way. Middle also in some of the systems you get. Getting fresh, clean cut dentinal tubules, which are virgin looking, clean open tubules like this at the apical third was actually not possible in any system except lasers. That's why I'd say laser is here to stay, except for the cost, which we in India for economics, we have to think of those things also. Otherwise, that's the system we should think about. I'm going to show you a case here, 18 months follow-up. One of my friends referred this case. He left it because it's a bayonet shape, S-shaped curvature. I tried 2 visits and I could not get there with my mechanics. My files did not reach there. All I did was laser sterilization. I did a down packing. When I did the down packing, see this? I have GP point there and some sealer slipped till the apex. And in this picture, you see, there is a lesion the day I'm filling the root canal. And then I referred this to my dental friend at this point, and I told him, okay, you know what? You do the crown, we'll follow it up. I told the patient, if it doesn't settle, we're raising the flap, we're cutting the root apical third, doing an episectomy. But in 18 months, in spite of me not instrumenting, but I've used laser here, okay? Just the irrigation has reached to the apical third, hopefully, and the lesion from there to there has settled. So no mechanics, it's only biological. Instrumentation was not there. It's only irrigation and biological reasons. Can you pre-curve the file? Of course you have to pre-curve. I showed you a lot of activation methods. What I'd say now is, please pre-curve the file to understand and use it here. When you pre-curve, you can go into the walls. It helps you remove tissue tags. I also pre-curve my ultrasonic files. Like U files is what I use very oftenly. Lesser number 20, 25. After my canals are prepared, especially in re-root canals, because GP point gets stuck everywhere. The rotary will do a good job, the solvent, the heating instruments, everything will pull the GP point out maybe. But so much of things stay in the wall system because undercuts are present. If there's covering the root canal with GP points or my sealer, what my irrigation is nothing. I need to remove them, right? That's when we use this technique of pre-curving files and going into the walls, hitting the deck, hitting between the GP point, hitting between the sealer and the dentine and trying to dislodge them and activating them. So that's important. So as I conclude, I want to stick to a few things here. We have, I think I was given 45 minutes. I think we've done that, but we'll just give me 5 more minutes, please, and then we take questions. Irrigation, no rocket science again. Fundamentals. You have saline, you have hypochlorite, you have chlorhexidine, and you have EDTA. Saline is used most of the times to flush and clean it. I would say hypochlorite is here to stay. Chlorhexidine is very debatable. Some use it, some don't. I used to use a lot of it in chronic cases for my 2nd and the 3rd and the 4th visits in chronic, where I keep doing dressings. Today, it's a little debatable. Can it be used? Should it be used? You can, but don't mix them together, please. That's my only request. And the last, forget the company name. These are just representations. The last is called liquid EDTA. That's the one irrigant which is a must to be used, where you actually try and put that into the system just before you close the system for obturation. Activate it, remove the smear layer, remove the biofilm, do a disruption, disinfect the whole system by that. So quickly, we'll go with the protocol. After my master shapes, I do this. I use a 5% hypochlorite, 3 minutes. Aspirate it out. I may take half a minute for that. Wash it with saline. You know why? Because dried cells, tissue tags, they block the system. Again, aspirate it. Again, put hypochlorite 5%. Now, by doing this much, you know what? 3 minutes, half a minute, 1 minute, half a minute, 3 minutes. So I've already spent about 8 minutes here. I do this cycle at least 3 minutes with some activation sometimes. All the time, you don't need to activate. At least 1 to 2 minutes, activate it. Keep the hypochlorite. Once this much is done, put a hypochlorite for 1 to 2, put the EDTA for 1 to 2 minutes. Liquid EDTA. What is that? It's an etchant. Earlier, we had this Gluma bonding systems, right? It's an etchant. You put that, again, activate it for 1 to 2 minutes with any activator, mechanical activators, aspirate it, wash it off. Some books have said saline, some books have said hypochlorite. I would say hypochlorite for 1 minute because liquid EDTA is a soap. It's a soapy solution, very sticky solution. Wash it nicely with hypochlorite. It removes it entirely. But some books have said, then you can try and obturate. I would say no. Aspirate it, wash it with distilled water or saline. You know why? Because hypochlorite is a salt. The salt can cause brittleness of the dentinal tubules and can cause micro cracks or fractures in the long run. We don't want all that. I want to be very simple and practical. So this is the protocol I want all of you to follow after your master shape is done. Till then, you use what you want, doesn't matter. You use hypochlorite, you use normal saline, I'm okay because I don't count it as an irrigation at all. I use hypochlorite, of course. This is just a way to say. This is my first visit. Suppose a second or a third visit comes, use hypochlorite, wash off for a minute. Why? Because, use saline and wash off all my medicament, like calcium hydroxide or nothing, aspirate it, liquidity, clear the system, aspirate it, then put chlorhexidine, 2%, not 0.2, not 0.12. That's a mouthwash. 2% is not a stable compound, but a very potent compound, which lives in the principle of substantivity for a longer time. Activate it if you want, leave it alone if you want, but for 5 minutes or 2%. Aspirate it, and then you wash it with saline. Some said, can I leave chlorhexidine for a longer time? I would say no, because it can interfere with the sealer. There are interactions of this with sealer or calcium hydroxides. So wash it out. For me, saline or distilled water becomes my final rinse. And then I dry with paper points. Then we go with obturation. So first visit, it's a chronic case. Maybe it's a re-root canal. Maybe when I say old fillings, it's about the silver filling on the top. Remove all of them. Remove the old, whatever it is. If I'm using retreatment, I use solvents and I use salines, I use heats. When I reach the apex, hypochlorite is very important. Till then, to remove my GP point, to remove my core materials, I don't need hypochlorite. I can use any irrigant. Use water, how does it matter? But when you're in the apical third, you have to use sodium hypochlorite. Second is to reclean it. Some say I only use hypochlorite. You can do that. I do that sometimes. But in the chronic lesion, I like to give another irrigant there. It is called chlorhexidine. They can use. But my only request is, see this video, never ever mix chlorhexidine with hypochlorite. It's a simple thing. You have chlorhexidine and hypochlorite, both concentrated. One is 5%, one is 2%. I'm only putting a drop and drop and drop and seeing the real time what happens. It starts discoloring. I'm not worried of the discoloration. What I'm worried is, you know what? The precipitation. It can cause something called as PCA, called parachloroaniline. This is not a good compound, you know. This compound can be cancerous, they say, maybe. So it's contraindicated, yes, but it causes a precipitation which needs instrumentation again to remove them. That's what I don't want you to do. So think different. Don't mix the solutions, not needed. If you read some old papers, a lot of researchers have mixed these two irrigants in a milder version. So that's what it is. So I'm just running the system and see what happens at the end of it. See, we don't want that. So sometimes there are doctors using calcium hydroxide, but it's oil-based, Vitapex, Metapex, iodoform-based. You can't use liquidity to remove it. You need citric acid, citric acid, a lot of activations. That's why the Western dentists, the international speakers, they don't like calcium hydroxide only for this reason. It's not possible to remove 100%. Like, see this. These are some of my cases where we were asked to push the calcium hydroxide beyond because of iodoform. Iodoform is good for the bone. It heals. True, it heals. But you don't need to go so far. If you want a good root fill, if you want a good lateral fill, you need to clean the system. If the system is not clean, you're not opening the portals of exit. I'm not asking go after the lateral canals. First, become the main canal dentist. That's good enough. In the process of you cleaning the system, if lateral fills happen, excellent. So I think with that, I'm going to conclude my presentation. Like how Shanuff introduced me as the founder of One Dental. Yes, we have an online platform. It's a closed platform. There are a few things which are free, which I want to give you. Please take the picture of this. You have to use this code OD1. OD is One Dental. OD30. You can use this code. You can get 1,000 rupees off. You can see about 30 videos free. Even if you don't want to become a member by paying, you still have some free stuff there. Some are with a fee, of course. So you have about 15,000 minutes of content. It's not about only endo, it's about general dentistry with Indian and international speakers. There are course, certificate courses, and many things. Please go to the website whenever you get a time. And even if you spend 15 to 20 minutes a day, 1 year is not enough to complete the entire curriculum, and we're still adding. So I wish you all take the advantage of this. And it's about 5 years old, and we have got more than 30,000 members in our systems who are GDPR compliant. So I wish you all come and join this. If you made this picture, how to become a member is go to the One Dental website, go to the member page, click into the membership and add to cart, enter your coupon code OD30, and then proceed to checkout. I think with this, if anybody happens to come to Pune, that's my email ID. This is my clinic. You're most welcome. With this, I'd like to thank Shanuv and his entire team, Safe Dental Updates. A big thank you. This is my classical signature. I always do. Thermoplastically, I sign off with a big thank you. It's an obturating material, a flowable Garapacha. A big thank you to all of you. Thank you for inviting me here. I know I could not give my early dates. Shanu knows it. I travel a lot. I have a lot of commitments, but I'm glad we made it. Thank you, Shanu. Thank you.
Thank you, sir. Thank you so much, sir. I think we have few questions here, which is relevant to the topic. Okay, I'll read out each one of them. Okay, so the first question is, for laser irrigation, is there any certain preparation should be done?
Yes, the preparation, see, I can show you videos where you don't need to prepare. Like when they give you acrylic blocks, they'll show you an 8-number canal, 10-number canal, and then you prepare in the acrylic blocks to 25 or 30, right? We have done studies on that. We put a drop into the canal where the irrigation, the colored liquid I'm talking, didn't go inside. We used a laser and we fired at the entry point and the solution was pushed into the systems. That's the beauty of photon-induced photoacoustic streaming. That's called PIPS tip. PIPS also has copies like preciso tips, X-pulse. Today there are sweeps, short wave pulses. So many of those. So, but if you ask me, yes, prepare the canal first. Minimal preps are enough, they say, because we're talking of minimally invasive endodontics. But having said that, when you say minimally invasive endodontics, I want to do the preparation of the sizes as much as 25 minimum. Taper, not 6, 7, 8 anymore. Taper should be just 4%, more than enough. So that's all what I want you all to do. So please try and use the preparation that much and keep it 20 to 25. Then even the laser will work. Just give me a minute. I want to just fix up my batteries. My laptop is running off. Yeah, sorry.
Okay, sir. So
Very
shall
sorry.
okay, sir. Shall I read the next question, sir?
Yes, please.
Okay. It's actually a question. It's actually my personal question, sir.
Yeah.
So what's your thoughts on editronic acid, sir, as an irrigant?
What gadgets you're talking about?
So the editronic acid as an irrigant. The
editronic. Okay.
Yeah,
editronic acid, definitely, yes. It all came because of one of the good studies by Matthias Zender from the Zurich universities. Yes, it can be used. It's used in combination of hypochlorite and editronic. There are ready-made ones. There are freshly made ones. It's having good results. It has good studies on them, but you have to freshly make it again. There's a capsule that you get. You put to hypochlorite, make a solution, freshly prepared, and then it's done. You can't use it for a second patient. So that's another activity by itself. If you can go for it, definitely. You know what? Then you possibly may not need liquidity also, because it does. See, these are all like earlier. Many people have used many things like Twin Clean had come, many other chemicals had come earlier. But today editronic acid can be used. So yes, it can be tried. It's already in the market. Some of the companies have it. So I think you should try and using that. Yes.
Okay, sir. So is there any certain indication for sonic and as well as ultrasonic activation?
If you ask me, sonic will do something called as acoustic streaming. You know what's acoustic streaming? When you put a solution like a guitar string, when you pull a guitar string, it's got nodes and antinodes. Imagine the solution now. It'll move like that, right? So it's moving from one